celebrate World Homeopathy Day. The, Han- Hello. The Hahnemann Oath says, "On my honor, I swear that I shall practice the teachings of homeopathy, perform my duty, render justice to my patients, and help the sick whosoever comes to me for treatment. May the teachings of Master Hahnemann inspire me, and may I have the strength for fulfillment of my mission." Dr. Hahnemann left us a legacy, a precious and beautiful science artistically practiced, which has been part of our lives for decades. He inspired us to dare to be wise and for the higher purpose of existence. Hence, let's all pray we acquire the grit and faith that Dr. Hahnemann had with our prayer. I request all to kindly rise for the prayer. हमको मन की शक्ति देना, मन विजय करे, दूसरों की जय से पहले खुद को जय करे। हमको मन की शक्ति देना, भेदभाव अपने दिल से साफ कर सके, दोस्तों से भूल हो तो माफ कर सके, झूठ से बचे रहे, सच कदम भरे, दूसरों की जय से पहले खुद को जय करे। हमको मन की शक्ति देना, मुश्किलें पड़े तो हम पे इतना कर्म कर, साथ दे जो धर्म का, चले जो धर्म पर, खुद पे हौसला रहे, बदी से ना डरे, दूसरों की जय से पहले खुद को जय करे। हमको मन की शक्ति देना। I request our dignitaries to kindly light the lamp and so that we can proceed.
लेट वाले पे Next time to picnic.
I request Dr. Shama ma'am to say a few words about today's occasion.
Good morning to you all. Welcome on a good Sunday morning for the celebration of Hanuman Day, which is celebrated as World Homoeopathy Day. Everyone says that homeopathy is an art and science. But for our master to prove that it is a science was not an easy task. He had to struggle a lot with the contemporaries of those times to even sustain in the field of medicine. Had it not been Dr. Samuel Hahnemann, I don't think we would have, in today's world, known what is science of homeopathy. To lay down those principles, to lay down those basic concepts about homeopathy is a greatest contribution of Dr. Samuel Hahnemann to the humanity. And to that great soul, this is our humble attempt on the part of our institute to pay a tribute on his birthday. So, to grace the occasion, I invite Dr. Prabhakar Devadiga to, sir, please come on the dais. I also, Devadiga sir, it is my privilege to have Devadiga sir as my teacher in my CMP days. When we entered in our first year of BHMS, he was the medical officer and we had the privilege of attending tutorials in small batches with him. And the amount of interest that he and Dr. Vijay Vaishnav as MOs have inculcated in us, that is a great gift that I carry till today. I also invite Dr. Kumar Dhavade sir to come on the dais. I invite Dr. Kapse sir to please come on the dais. And last but not least, I invite Dr. Bipin Jain sir, our principal, to come and grace the dais. Thank you, sirs. And now we start with our program of Hanuman Day celebration. I would like to invite Dr. Kapse sir to give a brief introduction about today's topic and about today's main speaker, Dr. Devadiga sir.
Good morning, everybody. Today we are celebrating Hanuman Day. We are fortunate to have Professor and HOD of organon and homeopathic philosophy from CMP. In a sense, we studied together. Dr. Goda sir, Sujata madam, Prabhakar, Nimish Mehta, they were all colleagues, 1 year junior to me. And Prabhakar was always the scholar and the topper. Most sincere, hardworking. So he topped LCH, he's a gold medalist. And since then, he is working at CMP since 1985. No doubt he is a professor of homeopathic philosophy. But what is unique about him is that even though he is not an ICRite, he follows all the principles and applies those principles in practice. That is his strength. He has always been interested in patient care and in areas which many of us don't like. He has worked as a registrar and RMO in surgery department in the formative years. And he has gone to the extent of setting up those OTs, participating in that, assisting in OTs, doing minor procedures. So what he's going to talk is not in the air. It is rooted in practice. And through that hard work, he has tried to explore the role of homeopathy in surgical. He is, I think, the busiest faculty in terms of OPD at CMP. Right? So patient care is the passion. And applying homeopathic principles in practice. So practicing pure homeopathy. I have seen there are two types of homeopaths. Some people restrict to a small number of patients. And there are some physicians who are mass practitioners. They will never see less than 100 patients in a day. So there are different temperaments. Then you develop those skills to manage that kind of practice. So Prabhakar comes to us with a vast experience of practice, and he has, I mean, I'm a little surprised. On one side he has handled surgical department, and the other side he got interested into psychiatry. And he has managed a lot of de-addiction, because the first article I remember reading that he had written was management of case of alcohol withdrawal. So he's a pioneer in that field. So philosophy, psychiatry and surgery. I mean, apparently diverse fields. So naturally he has made number of national and international presentations. I think he has also won an award for a paper that he had presented in the international conference on de-addiction through homeopathy. So he has a vast experience. There is a scientific side of him, there is a practitioner side of him. When he had come once as an examiner, I realized he has a lot of artistic side also. The music collection he had was the best I have seen. I still remember his music collection. So he's an all-rounder in that sense. But beyond all that, I think that he is committed to that mission that Hanuman gave us, to serve the sick. That is the passion for him, not the money. To serve the sick is the real passion. So today we are taking a topic about which many newcomers at least have a lot of doubts. And we get a lot of negative inputs as well as students. I still remember one of our teachers telling us, you homeopaths follow strict aseptic precautions. Don't touch the patient. You know, that kind of statements have also negative impact on you. And you start doubting the potentials of your system. Firstly, there are no surgeons in homeopathy. Since there are no surgeons, the first-hand experience is missing. And there is a lot that homeopaths have done in the field of surgery. Pre, post, during or avoiding. So there is a lot of scope. And that allows us to understand the potential of homeopathy, which we have not imagined. There are many times we are hesitant, we don't know our own potential. So management of surgical conditions, in a way, awakens that potential inside us. So I won't take much time. I think there is the proof of pudding is in eating. So I am sure that we'll listen and learn through a lot of cases that he has from his rich practice. I welcome Prabhakar to start his speech.
I request Dr. Clementi sir to kindly felicitate the sample.
पिशवी काढून दे. पिशवी काढायची. बुक ये.
Thank you, sir. I request Dr. Prabhakar Devadiga.
Good morning, all of you. I am audible. ये कोविड के बाद हैबिट हो गया है ना ऑनलाइन पे. Am I audible? Any which way. I thank the Dhawale Institute, Dhawale sir, Dr. Bipin Jain, and all my colleagues here for calling me on a Sunday, so I can do some good activity on Sunday. At the same time, I would like to thank the audience. Though being on a Sunday, you all have come. Some might have been forced, doesn't matter. But you have come, so I don't want to waste your Sunday. So let us talk about the topic. Today we'll talk about the topic. The topic is role of homeopathy in surgical disorders. Before starting, I would like to pay my respects to already paid here Dr. Hanneman, Dr. Dhawale sir. He has made an impact in a which way I has not been directly connected to ICR, but he has given me his book signed by him to me. This is what I can give you. We had a dialogue and then he said, sir, I would not be able to come here. I would not be able to spend that much of time. So he said, this is what I will give. And after that, we had quite a number of connections. Like, for example, the first tuberculoma case which we treated in our hospital, those days we did not have your WhatsApp, etc. But still, what was happening in CMP was known there in Pratna Samaj. And ye dawa kyun diya was the question. Patient, hospital ka, Dr. Bhatia ka. And dawa kyun diya? Tuberculoma patient. The first time the tuberculoma patient came, the patient was from Dr. Bhagwati and Dr. V.N. Singhal. These are the topmost neurosurgeon and neurophysician from Bombay Hospital. 9 months the patient was admitted in the hospital. Tuberculoma, patient had vomiting, right? The medicines won't work. उनके लिए foreign से injectable INH मंगाया. Now that is something very difficult. The patient sold off the flat in Mulund, 9 months admitting in Bombay Hospital, very good. Then the patient was finally sent to homeopathic hospital, to our hospital. Dr. Bhatia saw the patient. I want to pay respect to him because he was the first one who can tell. He saw the patient and said, "Kisko iodoform de do." Iodoform. Iodoform is our medicine. Iodoform de do. Iodoform de do. Then he showed me the points with our boric mein. This is iodoform. Third day we removed the rice tube. Fourth day the patient was eating food. After 1.5 months, those days it was the first CT scan. CT scan used to cost those days 10,000 rupees. Nowadays it is cheaper. 10,000 with CT scan kiya, tuberculoma reduced. The scope of homeopathy is what was left. लेकिन उनको आयोडोफॉर्म के जब tuberculum दिया तो सर का क्वेश्चन है, why tuberculum and tuberculosis patient? No, see, I hope you understand, no, the interest of patient किसका, no, everybody was working towards homeopathy. No, that's why my respect and my gratitude to Dhawale sir. And to Dr. Tiwari sir. What can I say? No, just before his demise also I had a talk with him, and a person with a gentle heart. I don't think I need to tell you, people all know more than every time he would say, and he would find it so difficult. एक स्टूडेंट को हमको एमडी में फेल करना पड़ा बिकॉज द स्टूडेंट्स वर्क वाज एब्सोल्युटली, और उसने थियरी में कुछ लिखा ही नहीं था, एक ही क्वेश्चन था, पूरा पूना से बॉम्बे आने तक का नहीं फेल होना चाहिए था। सर बोला सर इसको फेल मैंने नहीं किया, नहीं ये स्टूडेंट फेल नहीं होना चाहिए। सच ए जेंटल सोल, आई डोंट थिंक आई हैव सीन ए जेंटलर सोल देन दिस sir. So my respect to him, right? I had quite a lot of interaction. Some other time we'll talk about it. So we'll come back to our topic. This is one which usually I begin. In science, there is no place for dogmas. If it is a science, we cannot be fixed. If the dogma is there, then science is no more a science. So researcher is free to ask a question. A researcher need not necessarily have a research paper. Every day we are searching. Every day we are searching. So we have to ask searching questions. What can I do? So as a homeopath, my first idea was, why is this happening? What can I do for the patient? Now that question led to the answers which we are going to talk about. Question any proposition, search for any proof and to correct any fallacy. That's what a researcher is all about. So science, when it develops new dogmatism, it hinders the progress of science. So you cannot fix yourself after doing that. Also, there is always an opening. I will explain to you when we talk about a particular condition, you will understand what I am speaking. And if you break the dogma, then you can progress. Otherwise, you get shackled to our thought process ourselves. So that's the first thing which we need to learn. Why this topic? Because I can. Because you will. No? But why this is happening again? But we need to have a proper therapeutic pathway. So what is this? Meaning we learn, today I basically do not feel any need to prove that homeopathy works. If I am going to speak that homeopathy works even now after so many hundreds of years, then that means my basic philosophy is wrong. We don't need to. Now what we need to is to find the pathway, to find a system where we can say this is how we are going to do. There is a reason for talking like this. We used to send our students, Dr. Bipin will understand that we used to send our students to Bhatia Hospital also. Internship ke liye Bhatia Hospital, our college and ICI. So one brilliant student went to Bhatia Hospital and उनका term जब हमारे यहाँ आया तो मैं बोला कैसे लगा? How did you find? So they are very logical. अभी I was young, that time I would say anybody saying कि they are logical means मैं illogical. अब वो सीनियर होंगे तो अलग बात है, लेकिन एक जमाने में ऐसा कंसेप्ट है, व्हाट डू यू मीन बाय दैट? वो लॉजिकल मींस हम लोग लॉजिकल नहीं है। बोला हाँ सर, हमारे में दवा बदलते रहते हैं और वो लोग का दवा फिक्स्ड होता है। बोला सब में रिजल्ट मिलता है? नहीं, अगर नहीं हुआ तो दवा बदलते हैं। बोला वो उनके दवा बदलने में और मेरे दवा बदलने में डिफरेंस क्या है? व्हाट इज द डिफरेंस? बोला सर उनका एक प्रोटोकॉल होता है कि अगर ये दवा नहीं काम करे तो यू गो फॉर एन आयर एंटीबायोटिक। हमारे में से कोई प्रोटोकॉल नहीं है। Are you getting the point? तुम बोलो फिर वो रेमेडी रिएक्शन लिखा है वो सब भी तो हमारा प्रोटोकॉल तो है, ऐसा कुछ नहीं है नहीं बोल सकते। लेकिन सर वो तो एक जुना प्रोटोकॉल है ना, इट्स ए ओल्ड प्रोटोकॉल, यू आर स्टक टू दैट, योर Kent's observation, you are stuck to that, you are not making anything new out of it. This is how my students teach me. Every day my students teach me, it is the other way around. People think I am going to teach, it is not true, it is I am going to learn. Daily I learn from my students when they ask different questions, that is the challenge and that's the beauty of it. And that keeps me going. Somebody asked me, why are you young? Looking young? I said, because I am learning from my students. That's the only reason why I am looking here. So the whole idea is learning. So let's see a proper therapeutic way. So before going to that, let me understand from you, what do you understand by surgical disease? What is surgical disease? Anyone? What's a surgical disease? जल्दी बोलो, we'll have less time. I can carry on this for 8 hours. I have the stamina. थोड़ा जल्दी. Please answer. Youth has the right to be wrong. पहला रूल समझ लेने का, गलती करने से डरने का नहीं, गलती करेगा तो ही सही होगा. Yeah. What is surgical disease? What do you think are surgical diseases? Please. I have not come to take lecture. I have come to interact and learn from you. I said, मेरे को एक learning यहाँ से ले जाना है. Whoever, please. Whatever comes to your mind, doesn't matter. You can be wrong. Anyone? What's the surgical disease? Anyone? आप बोलो. ऐसे मत करो, ऐसे मत करो. I have not lived in Maine, Odisha पे ये सब words खाली सुनने के लिए नहीं. There to be words. बोलो. Good. Whatever comes to you, you can be wrong. Permission granted. YouTube बंद कर सकते हैं. YouTube बंद भी कर देंगे, वैसा कुछ प्रॉब्लम नहीं. For that moment YouTube बंद कर देंगे वो 2 मिनट. बिंदास लो.
For which we need any surgical intervention.
For which we need any surgical intervention. Anybody else? Anybody wants to add to this? That's a good definition. Very good definition. Anybody else? Anybody wants to say?
Mechanical cause and that can't be like we need intervention there. Medicine can't help there. So
Okay.
it can.
तो बेसिकली जहाँ सर्जन आ जाते हैं वो सर्जिकल डिजीज माना जाता है. दैट्स द फर्स्ट थिंग. लेकिन फ्रॉम आवर ऑर्गेनल पॉइंट ऑफ व्यू देयर इज अ डिफरेंस. From the organal point of view, there is a difference. So there is a true surgical disease which says these are the diseases which are caused from without, which requires mechanical aid to correct the same. So no medicine is required. Foreign body में remove the foreign body and you are all right. तो यहाँ medicine का कोई काम नहीं है. That's one. Then comes diseases requiring surgical intervention. If you read Sarkar, there is a further classification. और एक जगह surgical disease लिखा हुआ है. Where it requires surgical intervention. Why do we require surgical intervention? We require surgical intervention to prevent further morbidity or mortality. किसी का गैंग्रीन बढ़ रहा है तो उसका morbidity होगा. किसी का पस बहुत है, पेन बहुत ज़्यादा है and उसको टाइम लगेगा to remove that pus. That's also a surgical disease. No, those are also surgical disease, right? So that's how we are taught. So that is one. Hernia है. Is it a surgical disease or medical disease? Surgical. Now when we read hernia, it is written there are 2 types of hernia, right? One is just the beginning, Morgagnan bulge, where the weakness of the muscle is there. You give your medicine, and I have seen in 85% of the patient, lycopodium actually makes it disappear. Okay, and when the sac is formed, it requires surgery because otherwise it will not go back in. Because now the thing has become sort of irreversible. This is up to now story. Tomorrow it might change. Then hydrocele. I am just beginning with the small ones, then we will go to the bigger ones. Hydrocele, surgical or non-surgical? Surgical, yeah? It depends upon the size. No, after so many times, let me tell you differently. It is different. Depends upon whether it's a primary hydrocele or a secondary hydrocele. So in primary hydrocele, it will require surgery depending upon whatever size it does not respond to. Secondary hydrocele, however big size, it can completely disappear. How do we differentiate? How do you differentiate? Theoretically, you know कि filariasis हुआ था, ये injury हुआ था, ये सब समझ में. लेकिन physically, how do you differentiate? That is important, and most of the time, it is not taught to us. It is there in one small line in Belial law, but if we learn that, we know कि इसमें मैं treat कर सकता. That cases I take, I don't take the other case. So we have made a protocol कि this is the cases which we can take. Very simple. Next time you examine a hydrocele, you find that if you are examining an hydrocele and you can feel the testes separately, that is secondary hydrocele. When you are not able to feel the testes separately, that is a primary hydrocele. Primary hydrocele does not respond. Do not take up the case. So your percentage of recovery is better, no? See, we have to learn that. We have to learn what cases we can take. It's not only I can do everything. No, I can do everything provided there is a path forward. So that path has to be learned by us. So this sort of thing, because materia medica we all can learn. And we all continue to learn. So we learn newer remedies, we learn so many. आज भी अगर साल पर वापस पढ़ूंगा तो वापस नया चीज मिलेगा मुझे. तो वो तो it's an unending process. But knowing about the disease is very important. Aphorism 3 says knowledge of disease first. He's not talking about the medicines. Knowledge of disease. So that learning is important. And there is one more part of diseases which can be managed by medicines instead of surgeries. Now ये क्या होता है? What is this? There are patients who are having to undergo surgery because the modern medicine does not have anything to offer. What is seen is painful. Remove it, it cannot be seen. That's the concept. Example, PID. It is protruding, you remove it. और नहीं remove करेगा तो क्या होगा? Paralysis होगा, ये होगा, because that's the next step. Because pathology always talks about one-sided direction. Pathology कभी भी repair के बारे में बात करता ही नहीं. So therefore that fear, that anxiety which is developed in us, no, in most of the time in which we develop when we read pathology, because pathology textbook does not talk about repair. Repair is only 1.5 page. The best books of pathology. So unfortunately, the subject which is supposed to give good thing is not there. Stuart Close, Garth Borick and Henneman talks about pathology in a different concept. They say pathology is ever-changing subject, homeopathy isn't. It's a very important statement. क्योंकि अंडरस्टैंडिंग ऑफ पैथोलॉजी हर साल चेंज होता है. वो थोड़ा सा और ढूंढता है, कुछ और बोलता है, थोड़ा सा और ढूंढता है, कुछ और बोलता है. Like when we were student, पेप्टिक अल्सर वाज टू बी ऑपरेटेड. बिलरॉथ 1-2 सर्जरी हमको बाय हार्ट करना पड़ता था एग्जाम के लिए. How many of you know about Billroth 1 and 2? Now it is not there. So you can understand. Peptic ulcer काट दो. Do you understand? So there are diseases which can be managed by medicines instead of surgeries, and that is our aim. There are so many diseases which we can manage by medicines which was told as surgery. So like for example, commonest example, tonsillectomy. See the amount of tonsillectomy which has gone down because of homeopaths. That's the only reason, not antibiotics. Let me tell you. Adenoids. It needs to be operated. Time and again, all of you can treat adenoids. I don't need to teach about that. I'm not going to talk about it. So you can treat, do the X-ray, nasopharynx, lateral view before and after 3 months, you show to the patient. That is very important. आजकल का पेशेंट मैपिंग चाहता है. दे वांट मैपिंग कि वी आर कमिंग टू, वी हैव फेथ इन यू, बट वी नीड टू नो कि ठीक कब होगा, व्हेन विल बी ऑलराइट. सो इफ आई डू नॉट शो, बिकॉज सी वी एज सीनियर्स वी कैन मैनेज, हमारी सीनियरिटी इज इनफ, वो डॉक्टर कर लेगा तो भरोसा. बट व्हेन यू आर ए जूनियर हु इज स्टार्टिंग, स्टूडेंट पेशेंट इज गोइंग टू कंटिन्यूअसली क्वेश्चन यू, एंड द questioning is occurring because they belong to your generation. You are also questioning everything. It's good. It's good. But then there will be patients who will be questioning you. So you have to be able to answer them. So therefore, mapping your improvement has to be there. This is a must. So you should know what investigations to do, what are the scales to do. So everywhere scales become important. Scales become important. So now after we learn this much, what are the various diseases of surgery or which is taught in surgery which we can treat? Now I want some names. Bolo. I think now you people can answer this much, and definitely you know you can answer. What are the surgical? My question is very well framed. Surgery diseases which are taught in surgery in your college, in undergraduate, which you can treat with medicine. Bolo. Yeah. Huh? Abscess, very good, fantastic, very nice. Anything else? Hemorrhoids, fantastic. Anything else? Renal calculi, very good. Fibroid, fantastic. What else? Huh? Sebaceous cyst, very nice. What else? Appendix, fantastic. Appendix, what else? Gallstones, very good. So you have seen so many kinds. What other
Renal
kinds?
stones.
Huh?
Renal stones.
Renal stones, very good. मेरे पास बड़ा लंबा लिस्ट है. I agree with that. So let me ask one question. So let us make it very interesting. Renal stones, what are your limitations and why? Huh? Tell me what is the size you would want to treat and what is the size you can't treat. According to you, doesn't matter. Don't worry about others. Everybody has their own limitation, and that is good. And the whole idea is to push that limitation. Every time you go there, push it a little further. Go ahead. Doesn't matter. whatever, एक size बोल दो, 11 centimeter is too big. Maximum आप कितना treat कर सकते हैं? Treatable not treatable 1 meter, no. 11 centimeter नहीं, कितना? Maximum आप कहाँ तक जा सकते हैं? 11 centimeter तो 11 mm is enough, according to 11 mm. Okay, you have a reason for telling that. Can you tell me the reason why 11 mm? Whatever comes to your mind. Very good, very good. That thought process is good. Anyone else? 7 mm. Wow, what is your reason for 7 mm? तो तो नीचे गया.
Size of, you have to consider size of ureter as well.
Size of ureter. Actually, ureter is a stretchable thing. It is a pelviureteric junction. They say it is not so much stretchable. Therefore, you sure? It is 8 mm there, but doesn't matter. We take say 11 mm. ऐसा सोचते कि थोड़ा बहुत तो stretch हो ही जाएगा.
सर का फोन है
Silent कर दें.
I had one symposium today. Homoeopathy had the experience of helping 14 stone pass.
Yes.
And I had one experience in which a 5 stone got impacted.
Correct.
And right remedy was giving repeated palliation, but it was not
It was not moving. Yes.
So it is location, whether it is free or compacted, Saigon calculus, obviously.
Saigon calculus, obviously, it is
But
like
regarding size, I think still the matter is not settled. 7 mm to 14 mm is the range I have heard. But what is the damage post the passing of calculi and the stricture occurrence? I don't think there is any research on this.
so. Absolutely, very nice. Now we are coming to some point. No, there is something which we can now talk about. The size which is written in sonography. Have you noted what is how is the size written? 14 mm stone, 10 mm stone, 18 mm stone, and then we are taught that उसका तो 8 mm ही है size. और तो हम लोग सोचते हैं कि थोड़ा stretch होगा तो 11 mm जा सकते हैं. सर ने 14 mm का stone pass होता है. Forgot to bring the stone which I have brought. मेरा 18 mm में ठीक हो. मैंने तो ऐसे भेज दिया पेशेंट को कि आप जाके कराओ ऑपरेशन. एंड आई गिव द सर अभी दर्द के लिए कुछ दवा दे दिया था. दूसरे दिन सुबह सुबह आगे बिठाई लेके सर मेरा 40,000 बच गया. क्या हो गया? वो स्टोन पास हो गया. 18 में पास हो गया. वो कैसे हो गया? That's how we learned. That's the first route we taught. Then I learned it was a big scam. Learn the scam. Understand the scam. When I'm saying scam, it's not deliberately. It is what is written is a size. One size always has to 3 dimensions. And you have to understand the ureter will always grow the size like this. और वो अपने साइज से बड़ा साइज होने देने वाला नहीं है, तो पास होने वाला है. Understand this, that अगर वो impact हो गया, sir said, then it is not going to move. That after 3 months when you are doing a sonography, it is not going, it is impacted, your medicine is not going to act. Within 3 months it has to move. That is absolutely right. But even 18 mm, because 18 mm is in the length, not the breadth. Breadth लिखा ही नहीं होता है. So a research can be made. All of you can make research. Now you are MD students, so I am talking here at a different level. That means, according to you, you should be making research about. Ask your sonographers to give the length and breadth both, and then you will be able to put a map properly that it can pass. See, very simple logic. It कुछ बहुत difficult नहीं, but we never thought like that many times. With 18 mm, 8 mm, वो 8 mm ऐसा है, 18 mm ऐसा है. We twisted it in our mind 90 degrees. Think about our mind. It's very important to understand that this again is a small things. Small things we are made. We get to that conventional thought process. We need to think a little more. And that is always possible. Our master has always told that you have to be able to think a little more. Not a very difficult situation. So, that is renal calculus. We talked about hernia. We talked about hydrocele to some extent, right? Then there are quite a number of diseases which all of you are treating, like abscesses, then piles. Then piles, what piles you should not be treating? That's the next question. Going back to the book. first degree piles, second degree piles, third degree piles, ऐसा सोचते हैं. So thrombosed piles, gangrenous piles. These are the words. So can we treat or can we not treat? क्या idea? What are your ideas? आप लोग भी अपना अपना experience भी बोल सकते हो. Because see, I am talking about what I have learned. I am not speaking according to the script there. Whatever comes to my mind is
Those
well.
points with responsibility.
Yes.
Right.
Yes.
But the challenge that Modi sir used to give us, show me one hemorrhoid where grade 3 hemorrhoid has been reduced to grade 2 or 1. I have not seen any scientific.
Yes, we have not seen because we do not take photograph. और हमको लगता है खाली photograph.
It was open challenge to all of us. You show me one case in which grade 3 has been reduced to grade 1. Then you are treating the hemorrhoid. You can stop bleeding. But whether you are really helping that, go back. That is something where I have not seen any papers. Thrombus points I have enough experience.
Yeah, you have enough experience. What paper you have published?
No, I am not.
I'm sorry. So the question is the same thing. People do it and don't publish. I'm guilty of the same. तो मैं कोई बहुत बड़ा सिंगल से अलग नहीं हूँ. उधर ही same boat. Because we have not even bothered to take a photograph. So I started doing.
You know, the funny point was, I treated a granddaughter of a surgeon for thrombus points.
Correct.
And he was astonished at the rate at which it improved.
So the first thrombus piles, which was to be treated, like the patient came with thrombus piles. I will show the photograph, then you'll understand it better. थोड़ा आगे पीछे जाना पड़ेगा बहुत. Again, आगे पीछे doesn't matter. Since we are talking about that, we should. Bunch of grapes. What we read in our textbook. Bunch of grapes, no? Okay. And the date is there. 3rd September. 4th September after the treatment, this is what happens. Okay. We'll talk about it. I'll just first make you see the photograph. What is the change here? 5th September, what do you see? You saw the previous photograph.
Inflammation has come down.
There's something more. Inflammation has come down. See, again I'll go back. This is what I'm showing you. See this, and see this.
Slough of it.
Slough of it.
Slough of it.
Yeah. What we are doing is the skin is coming in. Skin is coming in, right? Skin is coming in. And the extra thing is slugged off. Extra thing is slugged off, right? This is little smaller. After that, the patient stopped sending the photograph. This was sent by the husband of the patient. तो ठीक हो गया, अभी नहीं दिख रहा है, फोटो नहीं दिख रहा है, कि नॉर्मल का फोटो नहीं भेजते, ठीक है? So we'll have to have a protocol about this. Now, why did we treat thrombus piles? Because it is written thrombus piles, you cannot say it will become gangrene, ye wo. So one of my surgeon friend, Dr. Pate, is a very good friend of mine. So he said the thrombus piles nahi treated. Then I asked him one question. That we use sclerosing agent, no? In piles they use sclerosing agent. What exactly you achieve with the thrombosis? When iatrogenic thrombosis is done, the patient doesn't die. But if he gets a natural thrombosis, the patient dies. That doesn't appear logical. It is not fitting the concept. If iatrogenic अगर control condition में आप thrombosis करते हो, अगर patient survive हो सकता है, तो ये भी patient survive हो सकता है. What is needed is taking care of the inflammation. So one of the simplest thing, an auxiliary mode of treatment we should learn, because see, patient has pain, and we should be able to take care of it. Our remedies act very well, no doubt about that. But patient को कभी-कभी immediate relief भी लगता है. So such patients where they have got abscesses in cases of thrombus piles, no, application of Epsom salt in cold water does the trick. The swelling diminishes faster. The patient gets relief in the pain immediately, and then you continue to treat. It helps. I have not done any research on when we are not given the Epsom salt this, but then Epsom salt definitely helps. So that will not cure the person, and then the patient completely, the whole thing disappears completely back. Okay. The remedy, what could have been here?
And it gives only very short time, 8 to 12 hours. If you don't give relief, the pain is so severe.
That is true. The relief comes very fast, and the remedies are also very easy to treat. हम लोग के लिए वो easy है. What are the remedies? Normal remedies which are there in thrombosed coils, which I have seen is aloes, muriatic acid, and bromine. What is given in our LS keynote is the very beautiful thing. उससे ज़्यादा कुछ जरूरत नहीं पड़ती है. Sometimes nitric acid, purine, etc. But ये aloe bromine, क्योंकि एक bunch of grapes 3 ड्रग में, तो हमारा काम कम हो जाता, right? And then warm application, cold application, saliva खाली एक ही patient में देखना है, जिसके लिए bromine दिया है. But that is the, who will think about applying saliva? Therefore, it is not there. But we can always say, apply your saliva and see. You might get dirty looks, but then it is worth thinking like that. Because see, that itself has got it. You all know that the saliva has got healing property. It helps. So that is another option which we have. So piles again, as Dr. Kapse has rightly said, whether third degree piles we have been able to treat and complete. We have actually, we don't examine in our clinic. The first thing which we need to change is that we need to keep the instruments for examination. You need to have the proctoscope. You need to do that, and we are qualified to do that. So anyway, so we can do that. The question was, there are some conditions known as what we call as surgical emergencies. Questions which we have: can we treat emergency? How can we manage emergency? Do we have specifics? How do I judge the severity? What about the medical legal part of the case? When do I give up and transfer and have a really cured the case? These are the questions which we need to keep on asking. You can photograph this and keep it, so that every time you need to ask these questions to ourselves. It's very important, right? When we are treating any emergencies, these are the questions which we need to have in our mind. Otherwise, then we can have medical legal cases today. So that clarity has to be developed over a period of time. It's a sudden state of danger, life and death situation requiring immediate action. You have to be the savior. Surgical emergencies, acute appendicitis, acute pancreatitis, intestinal obstruction, quinsy, DVT, thrombosed coils, etc. Now we all know that once we have treated them, we don't find it as emergency. Yeah? It's only till we don't treat it as emergency. Once we treat it regularly, I don't think today Dr. Kapsi sir will say thrombosed coils emergency हो गए. But for an allopathy, it's an emergency. वो patient को बोला जाता है कि भाई ऑपरेट करो, नहीं तो आपका नुकसान हो सकता है. Am I right? Even today they say that. So I will talk about one journey of appendicitis. I'm sharing this because I have treated more than 200 and odd appendix patients, acute appendicitis, and the journey was a beautiful way of learning what we can do. It was not only that, and what are the questions which we are asked by you. So therefore, I will take some time to talk about this. So let's see. First case. These are the advantages of treating appendicitis, of emergencies. Results are quick in emergencies. Their relatives see it in our hospital and they all know which is the doctor, right? Referrals are more. So it's the name, fame, money aa jata hai. And treating an emergency is at the end of the day you feel good. So doctor खेलते ना हम लोग तो उसमें one feather होता है. When we go home we feel very nice. We have treated and it is really satisfying. I have done something. We do daily. जब आप 100 पेशेंट देखते हो वो भी सेटिस्फैक्शन होना ही चाहिए, लेकिन हम लोगों का आदत है, we get habituated to seeing all chronic cases and treating. To an extent, I will give another example. No, there is a condition known as trigger finger. Again, a surgical condition according to the literature. But I am sure none of you think it is a surgical disease. None of us. None of us. As a student, I never thought it is a surgical disease. So the first time when I treated a surgical trigger finger, Dr. Mamtora, my very close friend, came running. Boss, क्या हुआ? क्या मस्त है? बोले क्या हुआ मस्त? नहीं आपने ट्रिगर फिंगर ट्रीट किया. बोले उसमें क्या हुआ? So it was like तो मेरे दाएं बाएं हाथ करके look. So we did that. तो बोले नहीं. We have to operate और तुमने बगैर ऑपरेशन का ठीक किया. Now can you imagine we didn't know that? Allopaths say no. And you know how many patients are of trigger finger there in the world? 1 million. If we charge $100 for them, that is a $100 million industry. खाली एक ट्रिगर फिंगर में हमारे बहुत फायदा हो सकता है. But we are not taking advantage of that. We need to work on that. We need to showcase. Now we know Dr. Keyur here is doing this digital thing. No, we have to work there at that particular level, and that can be done only in a postgraduate institution. So your assignment, your dissertation is one part of it. Do it. वो आप लंबा करो. उसका मैं नहीं बोलता. I do not want to speak on that. That you are going to do, you have to do it because that images. But in small things you do it, you will be so beautifully engaged in doing something which are the day-to-day activity. You write down things, you become the pioneer. The option of becoming pioneer in your field is so much open today. We are lucky to be in a homeopathic science. Because pioneering is there for each and every one of you. If I give today, you make me sit here, I will give topics to each one of them. I still have topics balanced with you. That many topics we have to pioneer. So, imagine, no, a case of trigger finger, $100 million. $100 million is a big amount of money. And if you corner that market, imagine. ऐसे बहुत सारे conditions. ऐसे बहुत सारे conditions. Therefore, what was an emergency is no more emergency. Initially, even for matter, your calcaneal spur was considered as a surgical disease. Nowadays, nobody operates it because that operation is a very horrible operation. उससे बहुत ज़्यादा patient को तकलीफ होता है. And we are able to manage such big spur also is managed. Thing is, बाद वाला X-ray किधर? We are resting on our laurels. हो गया ठीक. We never bother to see the next X-ray, and we think, is it reversible or not reversible? Is a question. Is it or is it not? Is it X-ray there? I am sorry, I am asking question to myself and you. So please do not consider this when I am asking question. We do not do the investigation. I am taking a link from Dr. J.R. Modi's book. When he says that you are not doing, is that we are not doing it the right way. We are doing, but we are not doing it the right way. We can do all this. ये सब common diseases है. आप इधर बैठे बैठे भी research कर सकते हो. Think about it. Calculus पर कितने आते हैं? Enough cases. कहाँ है document? We are very happy. Law of similars. Good, contented people, but not enough. So we need to put that. Now again, that is more than $100 million. It's a $300 million industry. आप सोचो यार कितना पैसा बना सकते? पैसा बनाने के लिए बना सकते, but you have to make that and become the pioneer. No, all of you can become the pioneer. Small things. Don't go for big things. इससे कुछ नहीं होने वाला. कर सकते हैं, लेकिन पहले ये तो करें, छोटा-छोटा. So when I am taking these surgical diseases, I am trying to say these are the surgical diseases which we can actually write papers on small. They are short-term things. Short-term करेंगे, and we can do that. And students can do that. See, as teachers, no, unfortunately, like in my OPD, in my clinic, extreme busy, and therefore all of seniors will say, we are busy, we don't have time. But you have time. You are our strength. You are our strength. And whatever you do, you are doing for your future. हम लोगों का प्रैक्टिस चल गया है, अच्छे से हो गया, सेटल हो गया, आई गॉट गुड इनफ, बंगला है, गाड़ी है, एक्सेट्रा वो सब हो गया. अब ये दैट, बट यू वांट नो, द कैलकुलेशन इज वेरी क्लियर. No, I was doing a calculation. I am talking about your future also. That I did a calculation that when I started my practice, it was 50 rupees charges, and 50 rupees is new case ka charges. Today we can go to 1000 or plus, correct? So 50 rupees charges था, और एक अमाउंट ऑफ पेशेंट देख रहे थे, और मैंने घर बना लिया 3 साल में. आज 3 साल में आप घर नहीं बना सकते. So I calculated. You require to work 18.5 times more than us. Seriously, I work 16 hours. मेरा multiplied by 18.5 आपसे नहीं होगा. So you have to change the strategy. You have to change the strategy because that is what worries us, our future. Don't you? It's always which worries us. कि मेरा future कैसा होगा? And why not work towards it? These are the ways, these are the international things which you can corner the global market. Please do this. Think about it. Just don't continue, come do your MD, finish. ऐसा नहीं होगा. Money is important in its own way, and don't run behind money. But then you have to be smart enough to earn money in a way. So you people can do. When I am talking about this topic, it is important for you. It's not like just one topic of surgery का लिया और therapeutics ने किया. वो concept ही नहीं होना चाहिए. Inpatient का advantage. If you are treating inpatient, awareness has to be there. Never leave the ward. I hear sometimes complain कि हमको ward में रखते हैं लोग. आता है हमको ward duty देते हैं. कुछ काम नहीं होगा. काम क्यों नहीं होगा? ढूंढा खुद ने. Have you tried? Introspect. Ward में क्या कर सकते हैं? I would not leave the ward. तो वार्ड छोड़ने का मतलब ही क्या है? तो you have to ask the question. हम वार्ड में क्या कर रहे हैं? जैसे रोज टीचर की वार्ड में क्या करते हैं सिखाओ. वार्ड में टीचर भागना चाहिए तुमको देखिए. तो टीचर तुमको सिखाना पड़ेगा कि what you have to do in the ward. So do not just sit in one corner getting disgruntled. I am telling you because I see that. वार्ड का ड्यूटी लोगों को लगता है वार्ड में क्या करने का? तो नहीं मालूम वार्ड में क्या करने का. That's the most beautiful place in the world. To learn. Not joking. Not joking. Not joking. I have learned. ये जो they are teaching no anti-miasm, intercurrent, ये सब पेपर पे था ना. miasm था ये भी नहीं मालूम था. बहुत साल तक तुम्हें miasm सिखाते हैं भाग करता है. सिक्योरिटी डॉक्टर बरवाले डॉक्टर बीच में तुम सिखाओ यार आपको नहीं आता. मुझे नहीं मालूम miasm. miasm में क्या पकड़ तोड़ है. No, this was the idea. I'm not telling I was right at that time. No, I have made a lot of mistakes in my life. But then that was the miasm नहीं ना मतलब ये pocket पे ना. ऐसा ये ICR वाले दिखाते हैं. That was my concept. Please, I'm not still I learned it in that IPD. miasm जब सीखना हुआ ना तो वो पेशेंट में ही सीखना होता है. ये लेक्चर में नहीं होता है, इसमें नहीं हो सकता है. तो वो miasm सीखने के लिए वार्ड में पेशेंट देखना होगा. तो I will give an example, smaller example. I am not really. So this was a patient who had come with breathlessness. So breathless, the mother child को लेके status asthmaticus, right? Those days we did not have this pulse oximeter, so oxygen level मुझे नहीं पता. It is useless. Let me tell you. We'll talk about it some other time. Doing this is useless phenomenon. But we scientific reality. So this patient was breathless. हमने पूरा हिस्ट्री ले लिया. I used to take good history. I take good history. तो पूरा अच्छे हिस्ट्री लेके एंटीमिनी कार्ड दिया. एंटीम कार्ड. पेशेंट ठीक नहीं हुआ. और मैं आधा घंटे से देख रहा था. ऑस्कल्टेट किया. रेस्पिरेटरी रेट वाज मोर देन 45. That is considered to be a respiratory. ऑक्सीजन दे दिया. ठीक हो नहीं रहा है. साइनोसिस नहीं हुआ. पेशेंट ठीक नहीं हो रहा है. ऑक्सीजन देने का उस टाइम में ऑक्सीजन की एक ही बॉटल था हमारे वार्ड में. वो कभी एक पेशेंट से निकल के दूसरे पेशेंट लगा देते. तो different types of working doesn't matter. Shama and all will be doing that what we are doing. So when we did that, patient was not improving at all. So मैंने जाके पेशेंट से पूछा कि sympathy is ना, as a young person we have more sympathy. तो मैंने जाके पूछा कि पेशेंट ठीक नहीं हो रहा ना, इतना तकलीफ तो कभी नहीं होगा ना, क्योंकि वो तकलीफ मुझे हो रही है पेशेंट को. नहीं वो चाइल्ड नहीं, ये तो कुछ नहीं, इससे भी ज्यादा होता है. फर्स्ट लर्निंग इससे भी ज्यादा होता है. What was troubling me was mother is there telling patient कि इससे भी ज्यादा होता है तो क्या करने का. आप क्या करते हैं? कुछ नहीं ना, उसको ऐसा उल्टा पलट के रख देती ना, वैसा बैठते तो थोड़ा अच्छा लगता है. सिम्पटम आ गया मेडोराइनम. वेरी हैप्पी मेडोराइनम मिल गया ना. मेडोराइनम दिया कुछ नहीं हुआ. मेडोराइनम दिया इमीडिएटली आई वाज गुड स्टूडेंट. आई एम टेलिंग यू अगेन मेरा मैथमेटिक्स अच्छा है. मैंने मेडोराइनम दे दिया, नथिंग हैपेंड. रेस्पिरेटरी रेट इज स्टिल हाई, मतलब मेडिसिन अच्छा सीखा था तो रेस्पिरेटरी रेट हाई, पेशेंट इज नॉट गुड, ये समझ में आता है, वापस हिस्ट्री लिया, वापस एंटीबायोटिक आया, वापस एंटीबायोटिक दिया, आता दवाई ज़्यादा नहीं आती हम लोग की तरह, पीपल नो मोर रेट, तो एंटीबायोटिक दिया, बाय द टाइम आई रीच द गेट ही वाज ऑलराइट. The first time I understood what is the magic of interference. The first time, उसको समझ में आ गया कि यार कुछ तो है. So, you know, you this learning, लेक्चर में कितना भी थियोरेटिकल टीचर सिखा दे, जब तक आप पेशेंट में नहीं देखते ना वो भरोसा ही नहीं आता. Then we start learning. No, so वो उधर रहा तो मैं ऑर्डर देके रूम में बैठ सकता था. वो पेशेंट स्टेप बाय स्टेप कैसे इंप्रूव होता है इज व्हाट वी कैन सी इन द वार्ड. सो देयरफॉर वार्ड इज द मोस्ट ब्यूटीफुल प्लेस ऑन अर्थ अकॉर्डिंग टू मी, इफ यू आर इन अ मेडिकल प्रोफेशन. एंड इफ यू कैनॉट रियली टेक एडवांटेज ऑफ इट, देन रीथिंक. You should. Every patient you see, you become master of managing patient. And if you really want to do the mastery, that is where the patient is. वो patient वहाँ है, मंदिर वहाँ है, भगवान वहाँ है, तुम कहाँ? It doesn't make any sense. It really does not make any sense. Huh? Please, it's a sincere thing. I understand, no? Today's generation, I understand the comfort level. It's how you make comfort. That ward becomes your comfort zone. That ward becomes your environment. कि उससे बाहर निकलते सांस फूलता है. You know, when एक पेशेंट का डिलीवरी के लिए ना, I went to भिवंडी, मैं am from भिवंडी, तो 15 दिन के बाद एक बार घर जाना पड़ता है ना, कपड़े वगैरह धुलवाने के लिए जाना पड़ता था उसको, तो गया भिवंडी. And that time I was thinking नाइट उठ गया, एक पेशेंट का डिलीवरी के लिए आई होगी, और एक्चुअली ऐसे वो पेशेंट डिलीवरी के लिए कि वो दूसरा रजिस्टर तो उसने भगा दिया, बोला अगर फैसिलिटी नहीं है. मैंने सब कुछ रख के आया टू स्टार्ट द डिपार्टमेंट. फर्स्ट डिलीवरी के लिए चाहिए तो दत्तू's वाइफ वाज टू डिलीवर, तो आई हैड मेड ऑल सब अरेंजमेंट्स. लेकिन फर्स्ट वी बिगिन देयर, तो उसने बोल दिया नहीं है इधर नहीं है, जाके प्रिंसिपल को बोल दे, निकल, वो लोग भेज दिया. आई वाज सो अपसेट. इट टुक वन मोर ईयर टू डू दैट, टू सेट अप. सो to understand that, no, to understand everything, you have to be there in the business. The mastery comes only when we are in the wards. So please rethink that ward is the most beautiful place. That gives you the mastery, because that you can see moment to moment improvement. नहीं तो सेमिनार में होता है ना, ये पेशेंट देखा, अभी आपने जैसे देखा ना, ये देखा, ये ठीक हो गया. She was having pain, so my classmate was in another OPD. I was in another OPD. There were two OPDs those days running. So I was Archana Manyar madam का OPD बाजू में था. I was in Dr. Patel sir's OPD. तो बाजू में से बैठ के प्रभाकर सर देखने इसको पेन होता है. Madam had gone out for some work, for some short work. So I saw that patient. I diagnosed ये उसको appendix है. So we admitted the patient. चलो इसको admit करते हैं. Okay. तो मैडम आ गई बाहर से. बोलो why did you admit? You admit क्यों किया? बोला एपेंडिक्स का पेशेंट है ना, एडमिट करेगा ना, ट्रीट करेगा ना. बोले किसने बोला ट्रीट करेगा? आप लोगों ने बोला, आपने थेरेपेटिक्स सिखाया ना एपेंडिक्स का 1 2 3. तो आपने बोला. एंड माय ग्रेटिट्यूड टू लेट डॉक्टर अर्चना, शी वाज सपोर्टिंग मी. देन एडमिट किया ना, चल गया. दैट इज द बैकिंग व्हिच आई गॉट. नो, दैट आई विल ऑलवेज बी थैंकफुल टू हर कि शी गिव मी दैट बैकिंग. दैट्स मतलब क्वेश्चन वाज ट्रीट कैसे करेगा? कभी ट्रीट किया ही नहीं किसी ने. बुक में अच्छा लगता है, सुनने अच्छा लगता है, ट्रीट कैसे करता है? हाउ आर यू गोइंग टू डू, व्हाट आर यू गोइंग टू मैनेज? पेशेंट का अपेंडिक्स फट सकता है, दैट्स द फर्स्ट थिंग. नो, वी लर्न अपेंडिक्स फट सकता है, दैट्स व्हाट द सर्जन टेल अस. Now luckily, now if you check appendix in your Google, it is written as medical emergency and not surgical emergency anymore. Okay. The question was ये appendix को treat करने का है, तो फिर मैंने वहाँ पर सर्जन को बुलाया, डॉक्टर के मेरे सर ऐसा. I'm telling them they have not done anything. तो उन्होंने बोला कि you are admitted, how are you going to manage? मैं बोला सर एक चीज मैंने सीखा था कि ये पेशेंट को 24 hours हो चुका है, so we can manage. First question was we can manage conservatively. Yeah, सर ये आपने सिखाया. I used to hold my teachers, therefore hold your teachers. लोग मुझे गाली देंगे, लेकिन छोड़ने का नहीं. कुछ पढ़ा है ना, पीछे पड़ जाने का. ऐसे क्यों पढ़ा है? कर किसी को बड़ी बड़ी बात करने देने का. जिसने सीखा they are responsible. That is the only way to go about it. And I'm telling you, teachers were no the only way. Most of the time you run away from the teachers because they भाग जाते हैं. Should be other way around. आपको तो teacher भाग. इतना questions पूछो. So then that's the only way to learn. I'm telling you. You should be a terror for the teacher. That they are going to ask. And imagine the beautiful thing which will come out of it. No? The teacher goes a level high. वो तुम आप actually teacher में से potential इतना निकाल लेते हो ना, so you will be, I don't know how well I say, you will be धन्य. The word is Hindi word है वो धन्य वही हो सकता है. लेकिन that you have to. Anyway, let's come back to the case. So this was the patient had severe pain. Examined here. You see this pain was growing. I will not speak this. Pulse, respiratory rate, palms were warm and dry. Inspection, ये सब तो all you know. I will go further. ये भी आपको पता है. Got patient. Then the surgeon asked me, what are you going to do? I said, we will follow the Oshner-Sharon regimen. So these are the things which are written in the book which you should follow. So Oshner-Sharon regimen ये follow किया. कि these are the things which you should do in any patient of appendicitis who comes to you or going to manage homeopathically. First thing is to be done this. Right? ये पहले कर लिया इसको. If you have any difficulty about this, we'll, after the lecture, I will go a little fast. Brine 200, 2 hourly दे दिया. Patient के बाजू में ही बैठ गया. I will treat him. क्योंकि हमारे पास एक सिस्टर थी, वो सिस्टर को कुछ भी बोलने का तो चले जाके सो जाते. तो मुझे भरोसा नहीं था. I sat down and the patients, there are two sisters. One was very good. Malayalam sister was there. She was very good. She was our strength. The other teacher was not so very good. वो चली जाती. आराम से. Self before others. Patient improved. The pain disappeared in 8 hours. Patient was discharged on the 4th day. ये first case. Patient को उसके बाद कभी appendix नहीं हुआ. I know that patient now since last 38 years. उसके appendix नहीं हुआ. इससे एक confidence आया. We started treating patients. तो OPD में patient treat करने लगे. And then one day the students को होता है ना surgical unit में कोई सिखा रहा था appendix it needs to be operated वगैरह. तो students से बोलते कि नहीं डॉक्टर देवाड़ीगा के appendix treat करते हैं. तो पता है ऐसे कैसे treat करते हैं? वो तो उसका relative होगा तो treat करेगा क्या? Will he take such risk? Very good question. Very good question. Very nice question. No, relative को treat करता क्या? Patient का risk वो time में ना consumer courts नहीं होते थे. तो ये भी हो सकता है ये मत होगी. तो उसको आंसर कैसे करेंगे? How can I answer that? And luckily for me, when my son was 3 months old, I got appendix. बच्चे ने थोड़ा लात मारा मैंने फट से लगा के दिया. फिर मैं सोचा कि 3 महीने के बच्चे को मारा क्यों? Then realized there was a severe pain and there was a reflex action. I remember that. So I examined myself. I said कि appendix है. I told my wife मैं hospital जाता हूँ. Went to the hospital. और surgeon को बोला मुझे तुम्हारे अंदर admit करो. I can't admit under myself, no? So he said, yeah, you have got appendix, which I knew. So he says, you have to operate. I said, I am not going giving a signature, I am not going to get operated. Well, how you are telling like that? I want conservative line of treatment, that's my right. Give me conservative line of treatment. बोलो नहीं तो फिर तेरे को antibiotics लेना ही पड़ेगा. Luckily for me, I am allergic to antibiotics. मैं बोला तू लगा. But इधर ही बैठ. वो जैसे IV लगा मेट्रोजन तो whole venous tree was immediately visible. निकालना पड़ गया. बोला नहीं. So now what to do? How can I operate you? तो antibiotics को allergic बोला I am allergic to all antibiotics. So it is not possible. So he said, no, write down paper, can't treat. Patient refusing. Give homeopathy ऐसे लिख. They said, okay, what do you think? I said, मैंने homeopathy दवा try नहीं लिया, मुझे मालूम था. Try नहीं लिया. I was alright. Next day when he came, I said, exam. You have no pain. लिखो. I'll go home. So then I said, this thing, I have to take risk on myself also. After that, I have taken a lot of risk. My son got it, and everybody got operated. This fine. So then this surgeon became a very close friend of mine. There is no enmity there. They have their own, how they have learned, they are speaking. It doesn't matter. He became a good friend of mine. They said, let us see, to कौन से cases लेते हैं, अपन करते हैं. So we learned after many years about Alvarado's code. ये क्वेश्चन था उसका कि कौन सा केस लेगा और कौन सा नहीं लेगा, because that was there. Because there were patients which he operated. तू अगर ये केस लेता ना, ये पेशेंट मर जाता है, इसको तो गैंग्रीन हो गया, इसको क्या हुआ. So then we had to find out. Then we found this Alvarado score, which all of you now know. It's not a new thing. So this is the Alvarado score. You can find on the net. We are using that. So usually we set up एक सेटअप किया कि 7 Alvarado score रहेगा तो हम लोग ऑपरेट नहीं करेंगे. 7 के ऊपर होगा तो Alvarado score more than 7 will operate. That was the limit which we had put. I don't know, we make our own limits. Then the time came to push that limit. After treating quite a number of appendix, we get little more confidence, and luckily when you start treating patients like that, patients only come. तो पेशेंट क्लिनिक में आ गए, पेशेंट को तो उसको एग्जामिन किया, आपको अपेंडिक्स है, यू गो एंड गेट एडमिटेड टू द हॉस्पिटल. हाँ डॉक्टर भाई वो कपड़ा वपड़ा लेके जाएगा, दिस इज अ नॉर्मल प्रैक्टिकल प्रॉब्लम. वो घर जाएगा, कपड़ा लेके आएगा, तब तक आप मैंने दवा दे दिया, मैंने दवा दे दिया, वो फिर मैं मेरा क्लिनिक खत्म करके हॉस्पिटल ही वाज एडमिटेड नाइसली. सर्जन को एंड एवरी पेशेंट आई शोड टू माय सर्जन, द सेम फ्रेंड ऑफ माइन. क्वेश्चन ही हैज टू सी, तो वो आके देखिएगा और बोलेगा तो ऑपरेट नहीं कराने वाला है. हाँ मैं नहीं कराने वाला, ये स्कोर है. हमारे स्कोर का फिक्स हो गया था कि 7 से बड़ा तुम्हारा, 7 से कम मेरा. That was the score. So then when he started seeing, तो वो पेशेंट देखा तो गप्पा लड़ा रहा है वाइफ के साथ. He was in severe pain and there. So तब तक इन्वेस्टिगेशन भेज दिया था. Now we have a protocol. Now so the protocol helps. Protocol, the patients remove WBCs were 23,000, which is a, for our protocol we have to operate. But when I came there to the ward, the patient was laughing and smiling and sitting and they were talking again. ये क्या अलग है? Interesting. सर्जन भी आ गए, बोले यार ये ठीक लग रहा है, कल देखेंगे. Patient also, the surgeon also said कल देखेंगे, ठीक है. Next day I did in the morning after 8 hours. The WBC came down to 8,000. That is the beauty. See ward में क्या सीखते हैं हम लोग, ऐसे सीखते हैं, ये step wise. तो वहाँ पर patient started, no, your remedy acts so beautifully that within 8 hours the WBC has come down to 8,000. तो ये एक सीख गया. अब 9 तक पुश हो गया लिमिट्स, तो पेशेंट पुश करते गए. सर्जन पे हमारा फ्रेंड को कोई ऐसा बदमाश तो है थोड़ा सा नहीं, तो ही वुड नाउ टेल द पेशेंट आप होम्योपैथी ले लो ठीक हो जाएगा, लेकिन क्या ये ना एक्यूट का क्रॉनिक रहता है. I like these challenges. There are some investigations you can write down. There are MLP-A, now they have used MLP-A, where we can decide or which can predict that there could be a gangrene or a rupture. We can predict around 97%. This test will be now, it is available but costly, it will become now easily available after some time. So now we have got some more tests and some more limitations which we can cross over. So now he would say कि नहीं नहीं ये पेशेंट को क्रॉनिक रहता है, एक्यूट ठीक होने का क्रॉनिक होता ही है, इनको होगा. तो I said how do I prove that our medicines act and it actually completely cures? Because see our definition of acute disease states what? Acute disease if not treated either ends into death or recovery. तो recovery हो गया, तुमने क्या काम किया? You are lucky enough there, you are there. ये क्वेश्चन आता है और आना भी चाहिए. So then therefore we have to set limit that this is my medicine acting and not recovery. We should be able to tell. That is the third part of our research which you can do. In cases, how do we decide if it is a recovery or your cure? ये important है. So that I will tell in pancreatitis case also. So let's come to this. So this patient, he said, ऐसे होगा. तो luckily now what we are doing nowadays, that in some patients, affording patient, we are doing MRI, appendix का. और appendix का उधर पे findings होता है. More than 1 million cases per year of appendix, ये अलग market है, opposite market. और सब million से कम कुछ भी नहीं है. Commonest non-elective surgery. Homoeopathy acts better and faster than existing conservative surgery. Newer objection. ये नया objection था ना, chronic appendicitis जाता नहीं है, होता है, will require surgery at a later time. Are you just taking care of symptoms or are you curing? Is the patient going into subacute or chronic? These are the various questions which we have put forward. Good, that is the journey. Every disease we are going to get new questions, and every new question requires new research. That's how we go ahead. So this was the exam. Evidence of acute appendicitis in the form of thickening and associated enhancement of walls and increase in diameter of appendix. With surrounding fat stranding and inflammatory exudates adjoining distal ileal edema is seen. ये appendix का picture है. ये patient को बोला गया था and he was a Parsi Baba. So they are little sensitive human beings. So they were worried. Doctor, you patient तो हमें शुक्र So this is the fear which we had. They said, okay, no problems. No, you are right. We need to solve this concern. ये था पहला. Then we got it done again after the treatment. Appendix is pelvic in position. Appendix exhibits presence of normal physiological layer in the appendix lumen of specification of the no wall thickening or anything. अब chronic appendix कहाँ है? So we can give results after results, and now we have got a good set of results where I can show that okay, after appendix, now see you have to understand this. Where patients can afford, please do the investigation. And we all collect our total this, and then we make a protocol. This is how we can treat. Are you all with me? So learning any disease today, what is curable in disease and what is curable in each case of disease. Our focus is what is curable in each case of disease. That I as a homeopath I can find a remedy. Our focus उस पे रहता है, which is good, nothing wrong. But what is curable in disease is important for marketing. Marketing our science, please understand. We can market our science in a better way, and that is important. And these are all things which are commonly seen. I said, कुछ भी diseases are not difficult, which we cannot. All of us can put together some investigations. We can do that, and we'll get a good marketing value. Why not surgery? There are some research which was done. You see, Parkinsonism increases if you do the appendicectomy. We didn't know that. Appendicectomy raises risk of lupus, especially in younger women. I don't know, ये research है, मेरा नहीं है, but it is there. So why not to do? जैसे दूध क्यों नहीं पीने का हम लोग लिखते, तो हम लोग भी लिख सकते हैं ना? ये ऑपरेशन क्यों नहीं करने का? ये भी होना चाहिए, ये भी होना चाहिए.
कल्याण में जो gynecologist था, he was reporting to have the maximum number of appendectomy in entire Kalyan town.
Possible, हाँ?
सर्जन नहीं करता था, ना वो करता.
वो करता है, gynecologist. हाँ वो हो जाता था, तो गॉलस्टोन में सब साथ में निकाल देते एक साथ. बच्चा निकाले बाकी कुछ को क्या I'm sorry, on YouTube you don't want to do that. क्या ना करो. These are the things which we should do. This all you know, I don't think I need to talk about it. This all you know how to go about it. So now whatever criteria which I have understood and I have put up is that less than Alvarado score, less than 6 you can manage at home. More than that you should keep in a hospital setup. That gives more credence. You can treat at home, but the credence which is there when the patient is getting admitted in the hospital and you are seeing hour by hour, that increases our repertoire. Where you can tell them this is what actually happens, and that gives credence also to the patient. को नहीं तो seriousness ही नहीं लगता है. पेशेंट को मैं डेंगू पेशेंट घर से ट्रीट कर सकता हूँ, पेशेंट को लगता ही नहीं तुमने डेंगू ट्रीट किया. वो पेशेंट को अलग तो डेंगू है, एडमिट हो जाओ, तुमको आईवी चढ़ा दिया, मेरा डेंगू ठीक किया. You know, I had a patient who was coming for vertigo. फिर एक दिन आके बोला यूएनडी में, डॉक्टर आपने मिस किया, मेरे को अपेंडिक्स था, उसको इसे चक्कर आ रहा था, डॉक्टर ने ऑपरेट किया, उसने 18 स्टिचेस किया, भगवान ने क्यों, लेकिन 18 स्टिचेस किया और मेरे को 36 बॉटल चढ़ाया. मैंने आस्क्ड अ क्वेश्चन, आपका चक्कर ठीक है? नहीं, वो तो है. It happens. Appendix चक्कर के लिए भी हुआ है. What I can tell about it, these things happen, but then it doesn't matter. Okay. The response in cases of Alvarado score above 8 should be within 8 hours, otherwise you may have a serious complication, because I tell you, we have seen Alvarado score above 8, and when we operated, we have seen gangrene. Because I will usually go in the operation theatre and see what is happening to that patient. So you have to be seeing both sides. You don't err. by being overconfident. So that means that thin line has to be maintained by us as of today. See, we push that limit of alveolar score 9, yes, but that doesn't mean that you have to be, bindas. That will lead to problems. So you have to be careful there. Is that clear, this topic?
One most important point which you have said is in the ward.
In the world.
Observing vitals and also looking for the local signs of going from
I think I missed saying one thing.
guarding to rigidity.
Yes. Very important. Very important. Thank you. There is one more important thing in this. When a patient of appendix with guarding peritonitis, there are 3 stages of peritonitis. Please remember. The patient, we are doing the blood pressure, etc. for a particular purpose. Patient's pain will disappear with the medicine. Don't think like that. Check. Patient will not have any guarding rigidity. एकदम नरम हो गया. Patient दर्द नहीं है. BP down हो रहा है, pulse high हो रहा है. That means the patient is going into the 3rd stage of peritonitis. You are going for a fatal condition. So that is must. That is a must. Sorry, I missed out because I ran fast through that examination. Okay. Common remedies. I will not go into the therapeutics topic now. I want to talk one little small case of pancreatitis, and then we'll go fast. So in pancreatitis, what I learned, I will tell you.
Branded acid is 90% cases. You know branded to be having a slow evolution. How is it that it has come up in rapid?
Appendix can never occur. Appendix, though it expresses acutely, is not an acute disease. If from our point of view, we are wrong. Myocard infarction is an acute disease or a chronic disease? Chronic disease. What we are seeing is the expression at acute level. Appendix is the same. It doesn't happen overnight. कुछ भी infection जाके appendicitis नहीं होता. वो food particles जाके वहाँ हो के फिर appendix expression होता है. So therefore it is a slow. No, when your question is fantastic. No, कैसे?
Ultimately, the physical hierarchy is inflammatory type and inflammatory type and obstructive type.
One which is inflammatory type has got lot of gradual onset and progress, and eventually it ends into obstruction. And there are primarily obstructive type which will have immediate impactful pain, which will not have physical. So primarily obstructive are not so frequent, but inflammatory progressive appendix are very common.
Correct. I think this mic is good. So, pancreatitis.
One slide.
I think we will keep our question answers at the end because it disturbs this flow.
Pancreatitis. Again, what we are learning, I will go short so that we have a limited time. In pancreatitis, the patient's condition is severe. It is written that acute pancreatitis patient requires admission and usually an ICU. And in ICU, in a patient of pancreatitis, the survival rate is not so great. If you read the books and if you read the statistics, right? And post-pancreatitis complications are more. These are the things which we have learned. So whenever a patient of pancreatitis goes, their patient is admitted in an ICU setup, mostly acute pancreatitis. He sent in an ICU setup. They will not admit the patient in general ward. Things today with newer antibiotics might change, but this is what the situation is. So I am talking about initially when your patient was admitted, then this was what was told, that non-affording patient was told you need to get admitted in the ICU, and the patient was not. Being in the hospital, that is the advantage. So that is the advantage which we had. Patient was told the condition is fatal, requires ICU, shift to municipal hospital. In municipal hospital, beds were not available, the patient came to us. Patient was already diagnosed with acute pancreatitis. Similar attacks, cooks mutton on Sundays, those are positive factors there. She was unconscious because of pain twice, breathlessness after walking. Severe pain in abdomen comes in waves, the attacks are very severe pain, patient writhes in pain. Craving mutton, oily things, sweet chicken, right? Not fast food. Yeah? Peritonitis is second, anger, contradiction, totality भी ले लिया. जो symptom है, of course she was irritable at that time too. This was the totality which you do. And the remedy I think is clear, no? What remedy? We gave Naxomic. Naxomic is the remedy which came here in this case. So we have treated different cases, different remedies. Yaha, I do not have too many cases of to tell you percentage wise. I have treated good amount of pancreatitis, but not to an extent. Where appendicitis, the number was very large. So parameters there again, Ranson's criteria can be used. So now we have started using criteria. This criteria help. So this criteria will decide in this patient the hematocrit fall by 10%. If it is there, you know that the patient is deteriorating. You should know the deterioration of the patient. More than 3, pancreatitis, severe pancreatitis. Less than 3. So you have options of deciding now severe and but severe pancreatitis, how it helps. This is the first case. So we had kept the patient in Nilbam for a longer period of time. We had to observe. That's how we observe, and then slowly we learn. Now, what I learned in cases of pancreatitis is that homeopathic medicine, the serum lipase and amylase comes down to normal within 48 hours. While in best of antibiotics, it doesn't come down. That is what we have to record and keep. That is what we have to record and keep. And the complications, post-complication, usually of pseudopancreatic cyst or thing, does not occur. And we have seen after antibiotics, this is no common thing. It is said to be around 70% of the patient develops pseudopancreatic. Now I am treating some of the pancreatitis, acute pancreatitis, जिनको stent डाला हुआ है and all those, and they are showing beautiful results. The previously the pain etc. was making difficulty. The patient had to come from Canada या यहाँ पर आके उसको वापस stent डालो, stent change करो. That has been stopped. So we have got so much big scope in managing pancreatitis now. So surgical interventions becomes lesser and lesser. And this is what we see in the patient. So this was the comparison which we did, pancreatitis. Case of thrombospasm we already talked about. And we'll talk about a little bit one or two different diseases. And then we'll come to the question answer session. Tuberculosis osteomyelitis. Tuberculosis is one of my forte. So treating tuberculosis has been from one of my patients was very kind enough to allow me to treat tuberculosis. After that, we did a lot of XDR, MDR and XDR cases, and they respond to homeopathy very well. The things are there are some things which we learn in our Matre Medica, and then when we started using that in the patients, our ideas changed. So today I will not talk about tuberculosis, but tuberculosis osteomyelitis. This patient came. This was what the picture was. Osteomyelitis is seen in the distal phalanx. Initial sheet is some wound in the great toe को उसको बहुत ज़्यादा ध्यान नहीं देते वो हो जाएगा, but it continued. बाद में investigate किया तो tuberculosis निकला, and this is what the patient. AKT not responding. AKT and osteomyelitis. Remember, osteomyelitis takes, especially tuberculosis osteomyelitis, takes a horrible lot of time, and most of the time it does not even respond to AKT. It takes a lot of time. With homeopathic, we have seen that resolution beautifully. You can see that. So these are the conditions which we can treat. Patient had this symptom: burning, aggravated midnight, discharge scanty. You will see the prescription has changed over a period of time. I started gaining confidence in homeopathy. My prescription became less and less. This is what happens. So initially, when you have less confidence, you prescribe more. When you have more confidence, you prescribe less. Yeah, somebody asked, oh, let us have a criteria for posology. वो सब बराबर है, लिख देंगे एग्जाम के लिए, वो तुम्हारा confidence है. Physician's confidence in the remedy which is prescribing decide the posology. बाकी सब है for writing the answer in the exam. Isn't it? We are judging the susceptibility of the patient to the remedy which I am prescribing. If I am confident of the similarity, I will prescribe less. If I am not confident, I will prescribe more.
So हमारे सेशन में इशू आया, ये उसका एक शेयरिंग है. The best response I have seen started after 60 days of administering cigarette.
तो 60 दिन वो वेट कर रहा था।
हाँ पेशेंट ना
डॉक्टर भी
दोनों पेशेंट थे एक पेशेंट था एक वो पेशेंट था नो दैट इज गुड so anyway this was the prescription and the patient did well and you can see the wound completely healed. I took x-rays. This is an interesting case during COVID times. I need to share this. One dose. Poor patient one dose. See, wherever I can repeat it too early, I will write whatever is done. ये patient एक dose से भी ठीक हो सकता है if the remedy is at hand. So that you judge. ऐसा कोई fixed rule नहीं है. Hahnemann ने भी very clearly लिखा है. All sophistry, everything is not useful. The patient teaches you the posology. He is very clear about that. Your patient will decide the posology. How you respond will decide your posology and nothing else. Initially stages में आपको start करने के लिए कुछ rules होते हैं which we need to learn susceptibility. It's important. But over a period of time your patient will decide. Patient susceptibility to the remedy and not to the disease. तो वो अलग-अलग है. तो disease की वो susceptibility अलग हो गया, आपका remedy का susceptibility अलग हो गया. So that has to be understood by us. Anyway, so this was an interesting case. Patient not in India, Iran during COVID times. Patient decided to take phenyl, toilet cleaner, helium, because of a fight with his wife. Okay, I will not tell because video में है तो उसके लिए वो fight किया and then he decided to take that and he. This is a picture. Completely burnt. His sister was our student, so she phoned sir, patient को ऐसा है, we are swimming. मैंने पहले देखा था they were in Iran से भी Tehran से around 100 kilometers away they were there, and the patient इसने ऐसे किया reason for caustic injury. You can see everything is burnt, no? All burn injuries into the esophagus, stomach. Reasons for injury: endoscopy, caustic injury, pre-medication, etc. Erosion in the bulb till the duodenum, पूरा burns. पेशेंट को उन्होंने कहा कि ये पेशेंट को हम लोग यहाँ से यहाँ काटेंगे. उनकी लैंग्वेज में लिखा हुआ है. I can't read anybody can read. इतना काटने वाले हैं. पेशेंट इन सेप्टिक शॉक. पेशेंट विल नॉट सर्वाइव. ये सब व्हाट्सएप का है. व्हाट्सएप से भेजा उन्होंने तो दैट्स व्हाई. तो व्हाट्सएप में भेजा तो ये इतना काटना है. फिर वो बच गया. तो फिर वो री-एनास्टोमोस करेंगे. Because they were not very sure whether he will survive. तो क्या करने का? What should we do? Emergency. I have nothing to lose. Patient दूर है, but patient has to lose his life. It's a decision has to be taken. I talked to the gastroenterologist here, Dr. Khanna और Dr. Soni. क्या उनसे भी बात किया. बोला कि वो patient we can wait. It's a possibility, but we are not sure because patient is so far. He is in a septic shock and patient requires surgery. Whether to do it surgery करने के बाद कुछ रहता नहीं है. It's difficult. I have another patient which I have treated, but then that will come some other time. Where everything is removed and still the patient now is gaining weight. Very interesting. Homeopathy the scope improves, no? So here, survival rate 50% उन्होंने बोल दिया. I said कि भाई तुम higher center को ले जाओ और जाते जाते दवा लगाना है. Homeopathic medicine, local application. यहाँ तो उसको ऑक्सीजन लगा दिया. कोविड टाइम, गाड़ी मिलना मुश्किल, फिर वहाँ से तेहरान लेके जाएगा. तब तक दवा दे देना. Let us see what happens. So then, by the time we reached the center there in Tehran, the doctor said we can wait. By that time, we had recovered out of septic shock. That's interesting part. Septic shock had gone, patient was better, and then they said we'll do the scopy. Previous scopy was here. Date 2010-2021. After 5 days. See the difference? But our allopathic friends don't sit idle like that. Patient ठीक हो गया, अब इसको dilate करना पड़ेगा. And this is one of the doctor with us. Stricture form हो सकता है. Stricture form हो सकता है. And I had an experience of 2 or 3 small children who had phenyl, and they were doing regular dilatation. When child को dilatation कर रहे थे very painful. एक का तो dilatation कर करके tear हो गया, laryngeal tear. So you can understand it's difficult. So then we had given medicines. I had given homeopathic medicines and found that उनको बाद में dilatation की जरूरत नहीं पड़े. I have a full lecture on what we call, if you talk about it, various types of scars, how it can be treated. All types, like keloid, celiac, everything, how it improves the homeopathy. But that is, we'll talk some other time. It's a very interesting topic. So here, you saw this. The question was, it needs to be dilated again. Well, not required. What did we do? ये अभी किया है, variant solve in March 22. He is able to solve completely. Patient अच्छा खाना खा रहा है, फिर भी बोला जा रहा है कि नहीं तुमको dilatation की जरूरत है. Well, the patient is eating everything, and that's the best proof, no? But it was told that you have to operate. You have to operate. So we have not operated. The patient just now is in Algeria, but he is completely all right. Now, what is the logic here? Let's understand that. Remedies initially was used as Cantharis, nothing great. All of you know that burns killing Cantharis is it, and Cantharis showed the response. And Cantharis, I can tell you, you can put your timer on. I can always tell some of the diseases, I have got a very beautiful experience. You can put your timer on. If a patient in the ward gets chills when you are giving IV fluids, timer on, APIS. 5 minutes, 300 seconds, the patient's chills will disappear. Guaranteed. These are guaranteed things, you know. That's the beauty of our own. So आप देख लो, लगा लो, टाइम देख लो और 5 मिनट में वार्ड में ये देख सकते हो. वार्ड में क्या कर then you know, this is how I learned. Please understand the timer on. So this also is like that. Cantharis में burning होता है, किसी को burn और उस टाइम में Cantharis लिया ना तो 15 मिनट में burning चले जाता है. This I had to apply because patient could not take anything. So local application, liquid application कर रहा था. wound यहाँ है ना, यहाँ apply कर रहा था, not in the direct place where the wound was. Cantharis was there. Later on we gave causticum to prevent the strictures. And then whatever little stricture was there, thiacinamide was given. This is a very beautiful remedy if used rightly. It actually cures quite a number of strictures. Dissolve scars, and it actually does. It actually does. So we have patients.
Different understanding of pathology.
Yeah, I learned that. I learned that how each scars in each different parts of the body. When I started studying it, I learned how it can be reversed. So as I told you, no, मैंने क्या बोला repair के लिए 1.5 page है pathology. I started my lecture like that. Remember? तो ये है कि because we are not studying that, we now start studying the other way around. We are physicians. We are supposed to be talking about cure. Pathology always talks about death. We are really pathological. हाँ? Potency, अब वहाँ पर मेरे पास limitation था, उनके पास Cantharis 30 यूज करने के मेरे पास choice नहीं था. But I would also give 30 or 200, usually 200. Thiacinamide is 30, usually 30. Then I have increased potency in some cases where they prevented. Then our regular way, once that potency is finished, is for 200 help करता है. Repeated देना पड़ता है. यहाँ पर मेरे पास confidence नहीं है, because it is not constitutional. No. You get confidence only when it is constitutional. Please understand. I will not talk about this Bartter syndrome because we are running late. Right? So Bartter syndrome is another disease where the patient had pus in the brain, full brain. Bartter syndrome क्या था नहीं मालूम. जल्दी से मोबाइल में पढ़ लिया तो मुझे मालूम पड़ गया. When the patient came, रुको, went outside, read it, and I knew what was Bartter syndrome. Right? But the problem was the pus which was there in the brain. Patient had already shunting was done. Hydrocephalus, shunting was done. Patient had complete pus, and they said nothing we can do now. All the antibiotics have been used, nothing can be done. So what we can do is we will put a drain and drain out. Pus was coming like thick fluid was coming. This boy is now grown up. 2005 का case है. Very high infection, right? Here it helped, the remedy which helped in this case, I am going fast, later on we will talk some other day, right? This is how the patient improved. WBC efficiency 23,600 in the CS, right? The third day the CSF started flowing freely nicely. This was the repatriation. इसमें से एक भी दवा नहीं दिया मैंने. कभी कभी ऐसा भी होता है. I took these symptoms. Repatriate करते हैं. Sometimes we don't do like that. Sometimes it doesn't feel right. So we gave this, and the remedy which was given was tuberculosis. tuberculinum, and tuberculinum 1M repeatedly brought it down very fast. Tuberculinum is a very good remedy in such cases, intractable cases where we are not sure. It actually does a very good job. Then this was a case of mucormycosis during the COVID time. I will finish in 1 minute. Mucormycosis was told that he will require surgery. Final result, what happened, the patient completely all right. It became small osteomyelitis and it came out. This is what he is now. उसका wound दिख रहा है? Scar. Mucormycosis was told that you have to operate, remove your orbit, completely all right. Different remedies at different times. We started with lachesis, then we gave silicea, and then finally we gave Hecla lava. And then it got cured. It's a fungal infection. We have treated fungal infections like treating any other fungal infection. We have treated aspergillosis, etc. So we know that fungal infection do respond to it. So this patient completely all right with because in North Gujarat, I must have treated more than 3,000 cases of COVID. Very interestingly, and not a single time I have been to North Gujarat during that time. So one of the very great experience, I was very thankful to that. We treated all kinds of cases till 30, oxygen 30. So homeopathy का scope इतना अच्छा. I think CT scan which is showing erosion, etc., which is completely all right. This is one. That's all. This is the last photograph. Now we can also treat carbuncles. Now we read in our Matra Medica, silicea is a homeopathic surgeon's knife. This is what it is. After giving silicea, no, not surgery has not been done. You can see the wound completely clean as if somebody has cut it and opened. And this I have seen in cases of sebaceous cyst also in the back. When we give the right remedy, it actually as if somebody has cut and taken it out. So heal kaise hoga? The interesting part of this is that the healing takes place so nicely, though it is opposite to the line, anatomical line के सर्जरी करने में हमको सिखाया जाता है कि आपका कट वो लाइन पे ही लेना होता है. यहाँ उल्टा होने के बावजूद उसका हीलिंग में वुंड नहीं दिखता है. That is a very beautiful thing. How did we learn that? क्या हो गया नहीं? How did we learn this? No, we have to go to our articles or our previous books. Kent has given very nicely in the chapter on syphilis. That syphilis, if the person has got an ulcer, it heals and the healing will show a thin blue line. But when your homeopathic is, when this line is not there, the patient completely heals. And this I have seen in, even in some cases of tuberculous sinus. When given homeopathy, the sinus healed and without a wound. I have seen extreme. Now we'll go to the extreme. That is rare. Please don't expect that every patient. One patient came, 1 minute only, 1 minute sharing, it changed my life. Patient came to Dr. Das Gupta, who was our surgeon, उनके OPD में है. I was the registrar. तो सारी पेपर लेने गए. उनके सामने बात करने की हिम्मत नहीं है. So you would say, patient type, young patient, breast cancer, the 3rd stage cancer, fungus हो गया था, nothing can be done. मैंने patient बोला nothing can be done, patient चले गए. 1.5 साल बाद एक patient आई, एक lady आई, 31 year old. बोले ओळख लगा, बोला नहीं, I didn't recognize. बोला तुम्ही सांगितलं तर मला पेपर काढून आणलं, त्याचं brought the paper. पेपर में मैंने लिखा था 3rd stage, fungating mass, nothing can be done, सब लिखा है अच्छे से. बोला मला तपासता का? तपासा तर नाईस, well found breast, nothing, no scar. चुकीचा पेपर आणला. म्हणजे माझंच नाव आहे, I am the same patient. बोला how is this? बोला I followed your instruction. आपने बोला कुछ नहीं करने, मैंने कुछ नहीं किया, ठीक हो गया. There's a learning. No, I didn't feel like Jesus Christ or someone like that. I said I need to learn this. This is very important. This changed my life. Understand? Yeah, this changed my life. चालू है ना? This changed my life. I went to, you sit down after the OPD was over. I asked her, what did you actually do? Yeah, ऐसा नहीं होता ना, कुछ मत करो, patient ठीक हो गया तो बहुत अच्छा था. Practice was easier. Well, then nothing happened in my life. There was a lot of irritation, doctor. When I came to you, I was very angry at my workplace. My boss would be very rude and so much difficulties. बहुत तकलीफ दिया उन्होंने. I would daily go with office में बहुत तकलीफ दिया. घर घर में भी ऐसे आई वुड फाइट विद माय फादर। ये मेरे रिलेटिव्स होते हैं ना, ये सब गांव वाले सब लोग बेकार लोग आते हैं हमारे घर में रहते हैं और ये टॉयलेट यूनिट का भी तकलीफ होता है, दे ऑल आर डिफिकल्ट। आई टेल माय फादर कि इन लोगों को आने दे क्यों देते हैं, सब लीचर्ड लोग हैं, no, इनको आने नहीं देते। दिस इज हर थॉट प्रोसेस एंड माय फादर वुड ऑलवेज से नो नथिंग डूइंग एंड देन आई वुड फाइट विद माय फादर। दिस वाज द सिस्टम। Then I came here and you said nothing to be done. So what I said, the first thing, nothing to be done. तो फिर मैं काम क्यों करूँ, काम छोड़ दिया। One invitation gone. Think about it. Then I said कि मैं बोला फादर से भी झगड़ रही तो मैं गाँव गई। Those same people, leisured people, took care of me. Interesting. They had no money. They had less money than us, but they were full of love. और वहाँ जाके रही ना तो वहाँ पर उन लोगों ने इतना अच्छा केयर किया कि I was so happy मेरे relatives के साथ कि I started looking at them in a new light and this happened. And that fungating mass did not leave a scar. Body's capability of curing is something which I learned at that day. So that's why I said every patient, अब उसमें मैंने कुछ भी नहीं दिया but I learned. So learning is daily. After that, nothing phases me in terms of taking up the case. But at the same time, not being cocky enough that I can cure all the cases. But you can treat any case which comes to you. Every case which has come to you has come with a purpose. It is not for somebody else. The case which has come to you is for you. So you have to treat, not for somebody else. With this, I would like to end. Thank you very much. Any questions? Any questions about surgical disease? Anything you think of any other surgical disease you can ask. I am ready to field your question because of time. Yes, we might not have touched on other diseases, but you can ask. Whatever I know, I will share. Any question?
After that tuberculosis did you follow
Tuberculosis वाला patient?
arsenic alcohol,
हाँ.
the toe?
Toe.
Did you follow it up with AKT?
No. See, once a patient has already taken AKT and not given, my concept is like this. When a patient comes to me, if I diagnose tuberculosis, I tell the patient that you have a choice of taking the medicine, which is allopathy or oral. That choice is there. So there were difficulties like tuberculosis is a notifiable disease.
That is why I
Understand this. Notifiable disease, but not untreatable. You cannot treat ऐसा नहीं है. You cannot treat ऐसा कहीं लिखा नहीं है. You can treat. Column अगर आप वो paper दो, column में homeopathy भी है. So this you can treat. Up there we have to be very careful. Sometimes the government officials can double. ये नहीं है ना अभी और?
hello, बंद करो का.
No, not on you.
Question answer बंद करो.
Question answer. I think we because some things we don't want on record like that.